Let's take a look at that video that you kindly brought to illustrate the process of putting the catheter into the artery and just sucking out that clot.
So this cartoon is showing a brain artery. That's the middle cerebral artery, the very important artery. Controls movement on the opposite side of the body, and you see a little clot there in that artery. Now, that's a tiny artery. It's about 3 millimeters, 2.5 millimeters in size. A little catheter is driven up there from the groin. There's a little wire in that catheter. We call it clot macerator, which is going to break up the clot. From the outside of the body, we apply suction to the catheter, and then we drive the clot macerator into the clot. And you see what's happening is the little wire is breaking up the clot, and then with suction, we're pulling the clot out and opening the artery. And you could see that taking place there. And this is a wonderful technological advancement, because not only does this allow us to open up the brain artery, but it allows us to open up the brain artery much quicker than we ever were able to before. You can do this, once you get up there and get it in place, you can do this within 30 minutes as opposed to spending 1 or 2 hours trying to inject medications there. Now, doing it quickly is very important because you lose about 2 million brain cells a minute when you have a stroke. So time is brain. Time is a lot of brain.
Mm-hmm. Is the saying time loss is brain loss?
That's right.
Wow.
Now, you had also showed us an animation that had a slightly older technology where the catheter goes in and through the blood clot sticks a wire, and the wire coils around and then pulls the clot back out through the catheter. Is that still used?
We still use that. That's another type of, we call it a thrombectomy, and thrombectomy is sort of a fancy Latin way of saying removing a clot. That's called the Mercy device, and we were one of the first ones to use that as well in Los Angeles. And that's a device where it's like a corkscrew that we put in the brain, and we use that corkscrew to grab a clot and pull it out. We just sort of lasso it.
That is so
You gave it a
fantastic.
nickname, Suzanne.
Yes.
What did you
Come
call
along, little doggy.
Procedure. How long does that procedure take?
About the same.
About the same.
About the same. It's really operator preference. Again, it's nice to have more than one arrow in your quiver, because when you have someone who's having a stroke and has a blocked brain artery, it really doesn't matter what you're going to use or how you're going to do it. You got to get it open, because if you can't get it open, the outcome is going to be certain. And it's going to be a bad outcome. So it's nice to have several tools, and we're very fortunate at this hospital to have so many tools at my disposal. I really feel spoiled in terms of the devices that I have that really allow me to do some very complex neurovascular operations, like the kind that we did on Elizabeth.
We are going. I don't want to interrupt you, but we're going to be continuing our discussion about Elizabeth's recovery when we come back. Certainly there are a lot of people who've suffered stroke who are walking and talking and conducting a normal life thanks to the work that Dr. Rappard and others at Glendale Adventist have been able to do with them. So stay tuned as we explore that facet of stroke here on Healthline.
Welcome back. I'm Gregory Zarian along with Suzanne Watley. And so far we've been talking about stroke. We have our guest Elizabeth Manaserian, who suffered from stroke, and also her doctor, Dr. Rappard, who basically saved her life. After she had a procedure, doctor, how long was her hospital stay, and how long was her recovery?
I think Elizabeth can speak to this better than I can.
I guess
having experienced it.
It took me, I stayed in the hospital for 16 days. And I was in the ICU most of the time, other than the couple of days that you saw me there at the NTU. But most of the time I was in the ICU. And then after that, I was also recommended to go to universities to get other diagnoses, to get second opinion, so to speak. But at the time, Dr. Rappard had already diagnosed my vasculitis. So it took me 3 months at USC Hospital, and they sent me to UCLA for another 3 months at the rheumatology department. And finally, they came up with the diagnosis of vasculitis, which was what originally Dr. Rappard had already diagnosed. So I made the full circle and came back to Glendale Adventist and Dr. Rappard originally, what he'd said originally. So that was my trip along the line. And, you know, I had to actually go through some minor therapy, some medications, and I was also being seen by Dr. Thompson, who was a neurologist, and he was working with my medicine, and I was taking a lot of medicine at the time, and some Imuran, which is a chemotherapy medicine. So a lot of medication, a lot of talking, a lot of consultation between Dr. Rappard and Dr. Thompson. They were my, doctors taking care of me at the time. But again, I'm just so grateful for their knowledge.
And I know, Elizabeth, you wanted to give props to the nurses who took care of you as well.
Oh, definitely, definitely. The nurses at ICU, the nurses at NTU, and I wish I could remember all their names, but 3 guys, Danny, Hugo, and Freddie, at the operating room. But they were just phenomenal. Their positive attitude. The guys were actually joking when I was at the operating room, trying to keep me happy and elated. Not that there is anything happy about surgery, but they just wanted to make sure that the patient felt at ease. As they were going through really most difficult time of their life. So everyone worked together, and I was just so grateful.
In regards to all of it before surgery, were you just ready to find a resolve? Like, I want this to stop now. Let's do something that.
Well, it's kind of like you're thrown. It's like a river, a river that rushes you through. You just can't swim back. There is no way. You just kind of go along with whatever the doctors are saying. It's kind of, in a way, it's kind of like a helpless situation.
Sure.
You just go along and hope that your doctors are right. And in that case, he was. So.
That must
so
give you
grateful
no
to him.
small amount of satisfaction to know that these lengthy tests at these
Right.
university hospitals came to the
Right.
same conclusion that
Right.
you
Right.
did. Dr. Rappard, a lot of the work that you do at Glendale Adventist would be on the university level.
I think all of it is. There's no doubt that this field was invented by the universities. As technology has allowed us to treat more and more difficult diseases, though, I think it's time that this level of care come down to the people in the community, and that's what we've done.
Mm-hmm. You're also doing some clinical trials at Adventist?
We are, and that's really part of our mission, which is to provide cutting-edge therapies in the community setting, and it's been a passion of mine, and so it became really an obvious conclusion that should include offering cutting-edge research. The stent, the brain stent that we used in Elizabeth, is actually part of a nationwide National Institutes of Health sponsored study now, and we're one of the sites here at Glendale Adventist is one of 2 sites in Southern California, and I think there's maybe 3 other sites in the whole state of California. We have a very important research study going on right now, which is using a drug to try and save lives in patients who have ruptured aneurysms. We're actually the only hospital in California that has that study. The universities don't, and several other trials. So I think we've been successful in not only bringing some of these technologies to our patients in the community setting, but bringing some of these research studies that you may not even find in some of the universities.
I find that fascinating, especially because it's happening right here in Glendale.
I find
Yes.
it fascinating too.
Well, no, just because it's, we think in a bigger scheme, and to know that we have everything that you're talking about right here in Glendale.
In little old Glendale.
Yeehaw, get along, little doggy.
Well, I think part of the reason for that is we're all university doctors. We all started at universities. I was actually an assistant professor at the University of Texas Southwestern, where I trained, and I stayed on the faculty before coming here. So we're all university doctors, and we wouldn't be anywhere without the universities. But there are some advantages to being in a community hospital. We're a little leaner, and sometimes could just maneuver a little faster, I think, and that makes it a little bit easier, I think, to bring some of these technologies to bear in the community. So we've definitely been able to leverage that.
When we come back, more on the miracle of Elizabeth's discovery. Stay with us.